Thanks. So we could actually have a health care reform bill, perhaps for the holidays. Well, we still don't know the answer to that, but what we are doing right now is taking a closer look at the plan that's beginning to emerge in the Senate. And joining us to talk more about this from Chicago is Kenneth Thorpe, professor of health policy at Emory University. Kenneth, thanks for being with us this morning.
Oh, thanks for having me on.
And we also have with us Sean Telley, Fortune magazine editor-at-large. Thanks for being with us as well, Sean.
Thank you.
Ken, let me start with you. Two big things that were presented in this Senate version that we're talking about this morning of this health care bill. One is the change in the public option. This was something that actually looks like there was a compromised reach on this. What does it mean, and what's the solution to be able to afford to cover larger groups of people without a public option?
Well, I think what they're talking about with a public option now is to have a government plan contract with a not-for-profit private health insurance company to provide health care coverage nationally, so that if you live in Albuquerque or Indiana, Pennsylvania, you'd pay exactly the same premium. So that was one of the premises, was that national availability put competitive pressures on the insurance companies, and everybody would pay the same.
Sean, is this basically a public option without calling it a public option?
Well, that part of it is not a public option because the government, through the Office of Personnel Management, would negotiate with private insurers the way that they do now for public employees. And the good element to this bill, as Ken pointed out, is that it is a national plan, whereas the insurance is regulated by state, and there are enormous differences in premiums across state lines. This would, in fact, inject some sort of national competition. The problem with it is that this plan already is facing very, very high premiums that are rising faster than premiums in the non-public sector. And also, you're going to have an adverse selection problem because you're going to have older, sicker people going into this plan, so they can't use the actual government plan, because it would shift the costs enormously to the upside. What they have to do is create a parallel plan. But the biggest single change is making Medicare available to people over the age of, starting at the age of 55.
Yeah, that's what I want to get to next, this change, dropping the age that you could actually opt into Medicare. Right now it's 65, dropping it to 55. How would we pay for that, Kenneth?
Well, that's going to be the challenge that the Senate is working on right now. They're looking at a couple of proposals. The first option would be to make Medicare available to adults 55 to 64, probably starting next year, but having seniors really paying the full price of it, about $7,500 or $8,000 a year for a single person. Alternatively, they're looking at options that would provide some financial assistance for people to buy those plans, and that's going to be one of the issues. How much does it really cost? How much does it add to the overall cost of the bill? And is it really going to be affordable for people to buy it?
It won't be. People today pay 25% of the cost of Medicare via premiums and taxes. This would call on people to pay the full actuarial price of the Medicare coverage. It's going to be far too expensive. It's going to require enormous subsidies. The question is, will those subsidies be higher than the subsidies that people who are uninsured would get through the exchanges? The history of Medicare is that the cost projections are always way off by a factor of 2 or 3 times. So this is a program that's already in the red by over $50 trillion. And to give you some sort of perspective, the deficit is around $1.5 trillion. So this would actually expand the problems that we now have with Medicare, which is the biggest budget buster
And can you agree with that take that that you're talking in the trillions already when it comes to underfunding? And if so, what is this bill going to, quote, bend the cost curve, which is what many proponents of reform have been saying needs to happen and will happen if it's passed?
Well, there are a lot of good new ideas in this proposal to slow the growth in Medicare spending in particular. I mean, we've got to go to the root cause here. Medicare costs are rising because we have an explosion of chronic diseases in the program, diabetes, high blood pressure. And secondly, we don't do a very good job of working with patients that have multiple chronic health care conditions to keep them out of the hospital, to keep them being readmitted to the hospital. In fact, 20% of Medicare patients are readmitted into the hospital within 30 days. So there are some good provisions that move us in the right direction to do a better job of preventing disease and doing care coordination. The question is, are we doing enough, and are we doing it fast enough? But at least they're going in the right direction.
And Sean, you say that we could be, in terms of trying to find a way to pay for this, what do you think the inevitability of this is in terms of finding a way to pay for it?
The only way this program can ever be paid for is through a value-added tax.
Which means what, a national sales tax?
A national sales tax, which is almost inevitable given that we cannot possibly grow our way out of these budget problems, and there is really almost no will to cut our way out of these problems. So the only way that we can move forward and come anywhere near balancing the budget is through an enormous new national sales tax. I think it's inevitable. And the other problem with this bill that no one is talking about is the fines on individuals in the Senate bill are so low. And in fact, if you spend less than 8% or over 8% of your income for a policy, you're totally exempted from any fine. So what people are going to do is they're going to opt in when they get sick. When the flood is approaching your house, you're going to buy flood insurance. And when you're young and you have to pay far more than your cost, which is also a feature of this bill, you're going to drop your insurance. So people will be going in when they get sick and dropping out when they're healthy.
I know the House version is a little bit more about on that front. We'll see if, as these move forward, that changes in this bill. But I want to thank both of you for your insight today. Kenneth Thorpe as well as Sean Tully. Thanks for being here. John?
Thank you.
Well, thanks for having us on.